Welcome to It's Your Case, presented by VetCT.com. I'm Heather, your radiologist on demand for this week. Here we have an 8-year-old female spayed Yorkshire Terrier with acute onset of lethargy and a single episode of vomiting. She has a prior history of pancreatitis. Now, I want to start by saying today's example is actually a very difficult case in my opinion. What I want to start by pointing out is the differences between cases where the radiographs can take us to a definitive diagnosis and the much more common situation where the radiographs take us to maybe a category of diagnosis, but we need to do more tests to determine what the full picture is. So this case falls into that second category for me. So let me show you what I'm sure about on the radiographs, and then we can talk about what I'm not sure about and what we could do next. When I look at the left lateral radiograph, especially for this case, I see an increased in soft tissue opacity here in the region of the retroperitoneal space. Let's go in a little closer so that we can see not only is there increased soft tissue opacity, but there remains some fat opaque features. This gives me the overall impression of fat stranding or mixed opacity, which is very common with fluid. You can see that the retroperitoneal fat is nearly completely obscured, but some fat remains, as if the fluid is interdigitating. Evaluating the renal silhouettes is quite difficult. This is border effacement created by the retroperitoneal fluid. Let me show you the ventrodorsal view so we can talk about another finding. When I went through the systematic evaluation of this case, one thing that I noticed when I looked at the gastric shadow on the ventrodorsal view, I see that there's the impression of a soft tissue band here. Some of this may be affected by superimposition of the colon. Let me show you how. When I trace the descending colon, usually I like to start with descending colon because it's the most easily to identify. And I trace it cranially. You can see here in the region of the transverse colon, we have superimposition of the colonic fecal matter and the colonic gas with this area where I'm concerned about a gastric lesion. I'll continue to trace the colon in the transverse and ascending region all the way to here. This gas shadow here is almost certainly the duodenum given its location. So, although I'm concerned about a soft tissue displacement here on the gastric shadow, I couldn't exclude that this feature is due to superimposition. So if I were to summarize my findings for this case, I'm very confident that there's retroperitoneal pathology. You can see it's a little less obvious on this view than on the left lateral, but that it's still there. The gastric abnormality is really only seen on one view, so I'm less certain about it. Therefore, here's how I would conclude. Retroperitoneal fluid and mass effect. I would also say that there's mild mid-abdominal serosal detail loss, although I'll point out that if we look in the falciform region, there's very well-defined margins of liver, and in fact, the liver is a little big. So my second conclusion would be questionable gastric mural wall abnormality. What can we do next? I think the most important thing to do when we're sure that there's something abnormal like the retroperitoneal space in this patient is to pursue it with either sampling and or additional imaging. Ultrasound can be a great way to look at the peritoneal and retroperitoneal spaces and may also allow you to confirm whether the gastric mural feature is real. On the other hand, CT examination can be valuable to give a full assessment of all of the abdominal features, including retroperitoneal fluid, peritoneal fluid if present, and gastric mural features. So both would be great options for this case. Be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your comments on social media.